Now that we have some orders for our trauma patient, we'll start an H&P. Click on the Notes section on the left-hand side and create a new note. The type will be History and Physical. The service will be set to trauma. On all trauma patients, the service should always be set to trauma. Conversely, on all acute care surgery patients, the service must be set to acute care surgery. Acute care surgery is a portion of the trauma service that handles patients who have emergent needs that aren't trauma-related, such as cholecystitis, appendicitis, and other emergent surgery needs. If the patient's not a trauma patient, but is on the TACS service, always set their note to acute care surgery. Otherwise, always set it to trauma. This distinction is important because trauma patients require other types of notes, such as the tertiary survey, and use different templates. Cosign is always required on any trauma note. The cosigner should be the attending, not the mid-level or chief. In this case, we'll use Dr. Owings. The trauma template used for H&Ps is the Trauma HP2 template. This should have been obtained in a previous video on obtaining the trauma templates. If not, go back and watch that video. After typing .trauma HP2, hit enter. You can then cycle through the note by hitting F2 multiple times. After hitting F2 once, we pop to the very top of the note at the chief complaint, where it asks us to select a type of trauma. This is where we'll state whether the trauma was a trauma stat, tier 2, tier 3, or trauma consult. A trauma stat is the highest level trauma, or tier 1 trauma. The trauma service takes care of these patients in the trauma bay. A tier 2 is a second tier trauma, also handled in the trauma bay, where the emergency room is primary for the patient. However, trauma still follows the patient in the trauma bay and can be called for admission at a later time if deemed necessary. A tier 3 is either a trauma transfer or a trauma consult. The distinction of trauma consult here is only to facilitate understanding. Both are considered tier 3s, and both are handled as trauma primaries. If there's confusion about what type of trauma you're currently seeing, ask your mid-level or chief. Since this patient was a transfer, he'll be a tier 3. LEARN stands for the Louisiana Emergency Room Network and is a system in Louisiana for deferring patients to higher level centers of care for trauma needs. If you're unsure what the answer of this question is, ask your mid-level or chief, or specify unknown. In this case, we'll say that the patient was not a LEARN. He was transferred from another facility. Here it lets us specify what facility he was transferred from. We'll say St. Francis Medical Center in Monroe. The history of present illness should explain the patient's events leading to their trauma. For instance, if the patient was a fall from standing, you should explain why the fall occurred. Did they have a syncopal episode or a mechanical fall? Did they have a history of seizures, etc.? In this case, our patient was an MVC. We want to explain here the events of the MVC, meaning what position the patient was in the car, where the car was hit, how fast the car was going, and other important details of the accident. The rest of the information is specified throughout the note. The scene information includes the estimated time of injury, whether or not the patient lost consciousness, whether or not they were intubated, whether they transported themselves or were transported by an EMS. Also, whether or not there is evidence of there being alcohol at the scene. The next section lets you designate the type of trauma, whether it's penetrating or blunt. You would delete all the sections that are not pertinent. So in our case, we'll delete all the sections that aren't MVC. Then we'll use the MVC section to further delineate the type of impact, position in vehicle, whether or not there was extrication, vehicular deformity, steering column collapse, ejection, or a death at the scene. We then get a basic history from the patient. If warranted and able, if the patient becomes intubated, often we have to leave these sections unknown unless there's family available. If there is family available, you should designate that the history is obtained from the family. Here you can gather the patient's medical history, surgical history, medications, allergies, and NBO status. Also, their history of drug, alcohol, or tobacco abuse is important. Review of systems is included here. Next are identifiers from our primary survey. During the primary survey, we assess the ABCs as well as DE. So we can specify whether or not the airway is intact, breathing, central pulses, whether or not the patient was hemodynamically stable in the trauma bay when they arrived. This section is, and all the following sections are, for our assessment at our facility, not how the patient presented in the field or at another hospital. That information could be included in the history of present illness. The Glasgow Coma Scale should then be designated with a total Glasgow Coma Scale and which sections were detracted from. The FAST scan is also included here, if performed. There's then a physical exam by systems, including head, neck, chest, etc. In each of these, you should state whether or not there's pertinent findings of trauma and explain what those pertinent findings are. In the imaging section, we include reads from an outside hospital if the patient came with CT reads or X-ray reads that did find traumatic or ruled out traumatic injuries. If the patient came with discs, you should specify here whether or not they did and what the location of those discs is, whether they were uploaded or not. For an intern, this is the majority of the trauma note. The labs will be pending, the problem list will be discussed in a later video, and the plan will be formulated by the mid-level and chief. Therefore, you do not have to include anything in the plan section of this note. Do not write that the patient will be admitted to trauma. The mid-level will handle this. The final box down here is important. Consultations box allows us to keep track of which services have been consulted and how quickly they responded to our consultation. Often, these services will be available in the trauma bay, such as orthopedics and anesthesia. If they are, simply designate that they were present in the trauma bay in which resident or attending was present. If not, then note the time that the service was paged and which person responded to the page. After you've completed your trauma H&P, you simply click Share. Do not sign the note or pen the note. You have to click Share, and this will allow the mid-level or chief to edit your note and fill in the plan, including the updated labs, CT reads, and problem list.